anyone at all can give us a quick recap of what he or she remembers or have learned for some few marks. Are there hands up that I'm not seeing? Is Jennifer's hand up? Or is Fatima's hand? As though nobody wants the mark, so.
So there's a hand up.
I can't see this hand though. Please, whoever's hand is up, please. The floor is yours.
Hello, good morning.
Good morning.
Please, what I can remember is the first meeting we did and the ultrasound where you said that it is in sound waves above 20 kilohertz. And that's one, it is only the bats that can hear that sound. Then you also said that the ultrasound is having please someone please interrupt.
Who is the one interrupting our conversation? Don't start getting minus for these actions. You are join with your mind muted. We have a dear friend on the line giving us her submission. Please, let's pay attention.
Okay. We also thought of the types of ultrasound examinations, where you said there were three main types. Then you mentioned that external, internal, that is, and then the endoscopic. With the external, you said that those ones are done on the abdomen, or like it is not inside the person, but the abdomen. Then with the internal, you gave an example like the transvaginal ultrasound, which is being done, and it is done with they insert the probe inside the person's through the person's the vulva, like through the birth canal. Then it will display whatever that they want to see. Then we also talk of the endoscopic, where you said it will be connected to a tube and then they will see the person's internal organs. Then I can also remember you said we have to pardon.
I'm listening, Jennifer. It's as though you want more than 5
I can also remember you said we have two main modes of the ultrasound, where we said the gray scale mode, then the Doppler imaging. Then you said with the grayscale mode, it is for you said that was the first, like that was the first one that they were using, and then yes, you said it was yeah, and you said it is still in use, like they still use it. And
that's great. That's great. If you were here, I would have given you your own Valentine chocolate. If we were in a class, I would have clap for you. But since we are not, I would commend you for.
So should I stop?
As much. Yes. So you have your 5 marks now.
Okay. Thank you, sir.
You are welcome. Eva, your hand is up. Would you like to continue for her?
Yeah, hello. I also continue from last week, which we did nobology.
Okay.
And you are saying knobology is the usage of instruments to view images from
Okay.
an ultrasound or a functional bottom of an ultrasound machine that allows one to view images or a
Okay.
display. Then you also talk of vital things we should consider before switching on ultrasound machine, which you spoke of the voltage of the machine. And you said much comes with 220 voltage, and there are those that are good for usage in Ghana, and few also comes with 110, but those ones are not compatible in the usage in Ghanaian system. You also talk of we taking note of uninterrupted UPS, which you also spoke of the power button. You spoke of the power button, and you said that one helps to connect the circuit to the machine. And then you spoke of the port, which allows the insertion of the probe to the ultrasound machine and helps to insert specific transducers into the ultrasound machine. And you also made mention of the depth, which you said it allows one to see more or to select an area to view during when you are scanning. And you also made mention of the resolution, which is the differentiating to which help us to differentiate images from each other. That's the ability to be able to point these things separate to each other, like separating organs from each other. And you also made mention of the measure, which you said when you select OBS 2 or 3, it helps to allow one to see the measures only, but only obstetric measures like the femur length and those things. Also mention of the caliper, which allow to do simple mathematical measures like the angle from one image to the other. Then also mention of the update button, which you said it also allow one to edit a point of measurement. Then you mentioned the gain button, which you said it allows to increase and reduce the brightness of the entire screen of the ultrasound machine. Then you mentioned the comment button, which you said it allows to label one image. Then the report button, which also allows to perform a summary of the examination one is doing. Then the save button, that one you said it also allows to store the images to be examined at any external hard drive or print, which help you to also print. So that is the little I also heard last week.
That is excellent submission, Eva. Very good.
Thank you,
Very,
sir.
very good. You've also taken your 5 good marks.
Thank you, sir.
Anyone else? Before we add some more. Okay, I think no hand is up. Or am I seeing more hands up? Okay.
Yes, sir, there's a hand up.
Esther.
Sir, you
Okay.
said last week that ethically your left hand does not hold the probe. And then the right hand too does not enter the patient history.
That's good. That's true.
And then you ended by giving us assignments.
Yes. I ended by giving you assignments. And about 67% of you submitted on time. The rest did not. And some did not at all. So we have a long way to go. Today we'll be touching on, we'll be moving on And we'll go on to what we call probe orientation. So permit me to share my screen and then we'll take off from there. I'm hoping we can all see the screen and can hear me loud and clear.
Yes,
Yes,
sir.
sir.
Do I have to match my voice or it's okay?
It's okay.
It's okay.
Okay,
Yes, it's okay.
fantastic. A quick recap on what we did the last time. We spoke about some of the knobs of the ultrasound machine, like my good friend said, we spoke about how to connect the ultrasound machine, the invaluability, or how good UPS is with regards to an ultrasound equipment. We also spoke about the volt system that we have connected to our grids. We spoke a lot about why we have to take patient information and which knob we use in taking that. We also spoke about reporting. We spoke about depth and zoom functionality, specifically spending a lot of time on the difference. Then we also spoke about the measure and caliper button as well, where we said that the measure button is used for measurement pertaining to a particular preset, whereas the caliper button is used for arithmetic measurements, and so on and so forth. We spoke about the color Doppler, power Doppler, pulse wave, and co. And an assignment was given under that. We spoke about the M mode, A mode, B mode, and also spoke about how to store, save, and print. On the probe orientation, we are going to discuss how and why what we see on the screen appear the way they do in relationship to the human body. So when you take the ultrasound transducer and you start your examination, there are particular ways that you put the probe on the body, and that way you put the probe on the body would be demonstrated on screen. So going back to this particular image, if you remember, we had this particular one where you have on screen here, okay, we can see that on this screen or on the images that we receive as clinicians, we usually see 4 sides to this square. There is a right, or when I say right in this particular class, anytime you hear right, I mean anatomical right. If you hear left, I mean the anatomical left. So when you have someone standing in front of you in the anatomical position, we imagine that the right side of that person would have been on your normal left. But if we do not specify what exactly we mean, it would be confusing for a lot of us. So in this class and on all our lectures with regards to ultrasound, we will denote this side of the screen as which is the anatomical right, to the screen. Then, of course, we have this side being the anatomical left. Then this place is the top part of the screen, and this place is the downside of the screen. We will define them as we move on. But note that on screen, there are 4 different sides. Again, this particular screen is a representation of what is going on inside the person's neck. So if you view this particular image closely, where the probe is in contact with the skin, okay, where you find the probe contacting the patient in this particular image, which is an external examination, you always have the probe coming in contact with the skin. So here, because the ultrasound probe is placed on the skin, the superior aspect or the topmost part of your screen is the skin part of the patient's body. So you have the probe aligning on top of the patient. Okay, so the top part is the skin, and the top part here is the skin. Now, if you look at the woman's hand closely, you can see that the probe is oriented horizontally. I hope we all know what horizontal is, the x-axis, with its length on the lateral side. That is what I mean. So you have one, it's being elongated, like x-axis. So when you have the probe in that position, there is something we call marker. The marker orients the professional on which part of this probe corresponds to which part of this screen. So on the screen, you can see a white dot here. In some of the images that you receive, you may see this white dot denoted as M, the function M. Sometimes patients and even some clinicians confuse that to be male, that the patient is going to give birth to a male. That is what the M is. But that is not true. The M represents marker. Okay. Then, of course, it may be demonstrated or illustrated as any other letter. You can sometimes see it as an O, or sometimes in a figure, such as a triangle. In either case, you would have a marker at one point or one side of the screen. If you have your marker on the anatomical right, then the corresponding marker on the probe should be on the patient's anatomical right. So when you take the ultrasound probe, there is what we call a marker point on the probe. It is a swelling or an outbulge that is usually seen on the ultrasound transducer. When you have that bulge, that particular bulge should correspond to the marker on screen. So in order for us to appreciate the marker, let me show you the marker on screen. Hello, so I'm back again. I think this image would show us or illustrate what I'm trying to say much, much better. So if you look at this particular image, this is a typical ultrasound transducer. This is what we usually term the curvilinear probe. And this is the curvilinear probe, whereas this one is the linear probe. The curvilinear probe has a curved footprint, whereas the linear probe has a flat footprint. But for today's discussion, what we are discussing are the markers. If you look at this linear probe, there is an outpouching here, this part that protrudes out like a pimple of a sort. That is what we term as the marker. In this particular one, you have this indentation here, demonstrating the marker. Okay, So it helps you orient the probe to the patient. So this region here is also the marker. On this probe, you can see that the out pouching is over here as a tiny out pouch here. In some instance, you'll find it at the top here. But whatever be the case, there is going to be an out pouching, like in these instances, or an indentation, like in this instance. That indicates the probe's marker of orientation. Then you come to the screen. On screen, like I was showing you in the very first image, there is a marker at the top. Okay, the marker could be on the left side or the right side, depending on the equipment settings. You can actually switch between it being on the left side to the right side and vice versa. In this instance, the marker has been denoted by a bunch of squares in the corner. This is just to tell you that this side is the orientation marker on screen. Similarly, you have the orientation marker on the ultrasound probe. Whenever you are trying to image a patient and you are in transverse, when I say transverse, you have this side of the probe or that side of the probe on the right or left side of the patient. So instead of holding it so that this side will be at the top of the patient facing the head, whereas this side will be facing the down, you are holding it in such a way that this side will face the right side, whereas this side will face the left side. So that is the X orientation. When you hold the probe in X orientation, it is very difficult to figure out the difference, especially if you are not the operating sonographer. So what we usually use are the landmarks on screen. So if I have a probe placed on a patient in the X plane, then it means that the right side of the probe will correspond to the patient's right side on screen. The left side of the probe will also correspond to the left side of the screen with regards to the patient's body. And then the top part here of the probe is the point that comes in contact with the skin. So that this place will be the skin. And then because the ultrasound is being shot from the probe from this point all the way, you have the ultrasound being coming from this top all the way. So it's as though from the probe to the body, you move from the top downwards. So from skin deep, as we term it. So if you are using a external transducer, you would go from skin deep. We don't want to say from the anterior to posterior because in some instances, you'll be scanning from the posterior aspect to the anterior aspect. Because anywhere you can put the probe, you can actually scan. So we go from skin deep. And the right side will be the right lateral side of the screen. The left side will be the left lateral side of the screen, corresponding to the patient's real anatomy. So the right side that I'm referring to, when we go and use the first image of this woman here, you will see that because it is in the X plane, where the left side of the probe is corresponding to the left side of the woman, and the right side of the probe is corresponding to the right side of the patient, the woman. On screen, you have the right side of the patient being on the right side, then the left side of the patient being on the left side. And that is how you tell. Okay, that is how you illustrate or demonstrate the two. please take note of the two very well. In this image, you can see that there is skin here, there are some anterior neck muscles, and of course, you can also see the isthmus of the patient's thyroid. Okay, this side here would have illustrated or demonstrated the right lobe of the thyroid, and that side here would illustrate the left lobe of the thyroid, because this side corresponds to the patient's right side. All of the structures here will be the right side of the patient, and all the structures here will be the left side of the patient. This particular thing that is giving black behind it is the patient's trachea. You also have the esophagus here. And that is what we mean by marker and probe orientation on the X or horizontal plane. The next plane we'll look at is the Y plane. Okay. The Y plane is basically holding this probe and then turning it from the X axis to the Y axis, making it straight. So instead of it being flat like 180 degrees on the neck, or yes, perpendicular to the neck, we'll hold it parallel to the neck. So we will rotate it 90 degrees clockwise. So whenever you are moving from the X plane to the Y plane, your marker in the X plane is always on the patient's right. So when you are moving to the Y plane, the marker should also be facing the patient's head. Okay, so you move clockwise 90 degrees. You rotate the probe 90 degrees clockwise, and then you would get your probe in the Y plane. That is also known as the sagittal plane or the longitudinal plane. Are we following? I hope we are following. Okay. Then we have the probe in Y plane from henceforth. When you do that, you have what we term another orientation on screen. Remember that when we were talking about the X-axis, we said that because the marker was facing the right side was the screen. Now that same marker is not facing the right side. It is now facing the head part. So now that it is facing the head part, I see two hands up. I want to finish with this, then I'll allow you to ask your questions. So keep your hands raised. Now that you rotate your probe 90 degrees clockwise, the marker part of the probe is facing the patient's head. So anywhere the marker is oriented to will be the same part it is oriented to here on screen. That is to say that when you are in longitudinal, okay, when you are in sagittal, the part here, instead of it being right side, will now become the superior aspect or the head part, whereas the left side will also become the inferior aspect. But the top to down remains the same. Hence, you have from skin deep. Okay, so let me look at those with their hands up. Bridget, your hand is up.
Sir, please, good morning.
Good morning.
Please, can you go over the S-plane? Like, I got lost, especially when you said that when you hold the probe or the transducer in X orientation, it is difficult to, the difficulty wasn't mentioned. So if you can go over the S-plane again, I'll be grateful. Thank you.
Okay. Philomena, your hand is up.
Yes, sir, please. It's the same as Sister Bridget just said. But I said, please, if what you are saying can be shown to us so that we will be following in that regard, I think it will help us better than.
That is what I'm using this image to illustrate, or you didn't see?
I saw it though, but say I was lost.
Okay.
Thank you, sir.
Anyone else? Don't worry so much. Just try and understand the concept so that when we start the practicals, you know what we mean when I say the probe marker. It shouldn't be something new to you. When I say the orientation marker on screen, which is this white dot, or the indicator that I showed here. You see, so when I say probe marker during the practical session, you should understand that this is what I mean. This particular dot corresponds to this particular notch here on screen. Remember, this is what you'll be seeing on the screen. This is what is giving you what you see on screen. So whatever this thing corresponds to on the patient's body is what you'll be seeing on screen to be its side corresponding. So you can see from here, okay? I'm coming. You can see from here, this notch here has a particular region here corresponding to it. Okay. This on this screen, the right side here, all the way to this side, represents this ash plane you are seeing here. Can you see this ash side of your probe? That is what we term as the footprint. This particular footprint is what will produce the sound and produce the image that we see. So if you've seen the image here to be flat, it means that this particular probe that was used to take it is flat. Can you see? So this image was taken using this particular image. And you can see that the footprint, as we term it, is flat. Hence, this side is also flat. Now, the thing that you have to note to get it very clear is that in order for you to know which part of this footprint correspond to which part of the footprint on screen, we need to denote it. We need to mark it so that anytime you are lost as to, for instance, if this marker was not there, how would you know that this side or this side corresponds to this side or that side? It will be very difficult for you to tell that this side here corresponds to this side and that side corresponds to that side. You may make mistakes. And this is what happens, especially when we are doing presentation in ultrasound. When you misorient your probe, okay, if you misorient your probe and you don't get it right, I am sure you have had instances where the ultrasound report is saying that the patient is having a cephalic presentation, but it turns out that the patient's presentation is breech. In some instances, the misorientation of the probe is the cause. Are you following?
Yes, sir.
Okay, so I would share a video with the course rep so that we would all watch it and see the very difference again. But the importance of this lecture is not for you to understand it outside the scope of practice, because it is very difficult for you to tell what I am saying without actually practicing it. If you don't have the probe with you, it is going to be very difficult to understand specifically what I am saying. But we all have to grasp the concept that this marker here corresponds to this marker here. Okay, so there is a marker on the probe and there's a marker on the screen. These markers help us tell right from left, top from down. So the part that, for instance, if I am to use my finger to touch this side of the probe, you would see a corresponding touch on the screen at this side here. You would see that something is touching and something is moving here. So that it will tell you that this side that you are touching is this side that you are seeing. If you don't see this marker here, it will be very difficult for you to tell that this side corresponds to this side or this side corresponds to that side. I hope I am clear now. So in the X-plane, when you have the probe in transverse or in an X-plane, if I am to illustrate or demonstrate, when you have if you hold your phone, if you take your phone and you hold it, hello, I'm hoping I'm audible again.
Yes, sir.
Yes,
Please.
sir.
So to recap, okay, on everything we've done, starting from the top, we have what we call the ultrasound transducer. Then we have the ultrasound screen. The ultrasound transducer, from what we learned in our first lecture, would have to send sound waves into your body. Then when it sends the sound wave into your body, it will receive it. The side that does that sending and receiving is this ash side or gray side that you are seeing here. These ash or gray sides are what we term as the footprint. The footprint is the sending and receiving part of the ultrasound transducer. So when I put this probe on you, it will send the sound wave into your body. When it is sending that sound wave, it will send it in a particular pattern. That pattern is represented by the curve or the nature of the footprint. So if the footprint is flat, the receiving sound beam would appear flat. If it is curved, you would see that the receiving sound beam would be curved as well. So on screen, you will find out that if this was to be on screen, you will see a curved nature also over here, just as this probe would be. But because this image here was produced using this probe, which is flat, the top part too is flat. Remember that the top part of your screen corresponds to the part of the probe that is in contact with the body. So if I put this probe at your back, this would be your skin, then the muscles, then it will keep going deeper and deeper and deeper. If I put it on your stomach or your abdomen, it will be your skin, then probably some subcutaneous fat, the muscles, then so on and so forth. So it will be going from the top down, will be from your skin deep into your body. This is true for both sagittal and transverse images. So when you are doing your examination in sagittal, or you are performing it in transverse or longitudinal, longitudinal can be exchanged with sagittal. Okay, although not all longitudinals are sagittal images. Okay, so your sagittal image is when you have this probe in this orientation where the top part, okay, the marker part is facing the head of the patient. So when I put this probe on the patient, if assuming this side is where the patient is, you have the head of the patient here, the neck here, the body here, and so on and so forth. But when you turn this probe flat, so I will move this side backwards like this, so that it will be flat. When it's flat on your body, like in this image. So over here, you can see that the probe is not oriented longitudinally, but it is oriented flat. So you have the marker at the opposite side. So the marker will be towards the operator, and then the opposite side of it will be towards the patient's left. When you have it in that orientation, that is what we term as the X-plane. And in the X-plane, we have already explained that in all instances, the top and down are skin to deep. The only differences lie on the right side and left side of the screen and what they mean in the different planes. So when you are in transverse, which is the X-plane, the right side will be the patient's right side. The left side will be the patient's left side. When you are in sagittal, the right side, now that your probe has been turned straight, the marker would move to the top. So the right side here would refer to the top part of the patient, whereas the left side here will refer to the downside of the patient. Am I making it clearer now? Is it clearer now? Nancy, do you understand now?
Yes, sir.
Okay. Any questions on that? Everybody understands? Okay. Martha is saying I should take it again. So what I was saying is that let's go back to our main image. Every ultrasound transducer has what we call a marker. The marker orients you. It tells you which side of the probe is where at all times. And then because the marker is telling you which side of the probe is where at all times on screen, then you need to have something that will correspond to that marker on that screen. And so the marker that you have on the probe corresponds to this marker here that we have on screen. That is the first step. So whatever this side of the probe touches will be corresponding to this side of the screen. And it is continuous all the way to the other side. So if I use my finger to touch this side, I would find out that here would show some changes. If I use it to touch it in the middle will show changes. If I use it to touch at the far side, the far side will show some changes. And as you have your hand up.
Yes, sir. So, sir, please, if I do get you, where the marker is that the anterior part of the transducer, so that where it is facing, it tells you that this is the superior part of the patient, and then the bottom of it shows the inferior part of the patient.
For the transducer, I cannot say that this side is the anterior aspect, because depending on how you are holding it and how it is oriented in your hand, either side of the four sides could be the anterior. Yes, Bridget, your hand is up. Bridget, your hand is also up.
Saying, so please, with the marker, are you saying that let's assume that we are taking the ultrasound on the person's tummy, on their stomach. So if I point the marker towards the belly button and the other side of the marker is facing downwards, going to the client's mons pubis, the images it will give on, or the images, like the image it will give on the screen would indicate that, okay, my marker is showing is pointing towards the belly button. Therefore, the screen, where the marker is indirectly, is giving me where the belly button is. So, like, the transducer is reflected on the screen based on where the marker is showing. So, it kind of tells you, say if you point it this way, look at the marker on the screen as well to tell you, where you've pointed is what I'm showing on the screen. Is that it?
Yes, exactly.
Okay, thank you.
So using this particular image to explain it further, you can see this square here is our probe, and it has been placed on the mons pubis of the lady. In this particular orientation, we have it in the sagittal. Okay, this is the sagittal orientation where you have the probe in its length. And then the marker is the red button at the top of it. The red button is towards her umbilicus, towards the head. So in this particular orientation, it is in sagittal. That is what we mean by sagittal. If I rotate this probe and turn it 90 degrees anti-clockwise, where this marker and the head will come, virtually it will become a plus to this, plus sign. Instead of it being like this, let's say we turn it for it to look like the minus sign. Then when it turns and then looks like the minus sign, that is the X-plane or the transverse plane. In that plane, you have this marker here towards the left, or on screen, the anatomical right. If you look at this particular screen too, you would see that this marker corresponds to this marker here. You can see a red dot here. So because this marker is in the sagittal plane and the red dot is towards the head, this side here of the screen will also be the superior aspect of the image you are seeing, because the marker is also oriented with the marker at the superior aspect of the patient. So in this image, this is how your uterus would be oriented. You have the fundus of the uterus, the body, the internal cervical os, the external cervical os, and the vagina. If you imagine it in actuality, the fundus is always superior to the body, and the body is superior to the cervix, and the cervix is also superior to the vagina. So when you have your probe marker in sagittal, the right side of your screen now becomes the superior aspect of the patient, where you find the fundus and co. Whereas the downside of the marker, the opposite side of the marker, would correspond to the inferior aspect of the patient in sagittal. Similarly, if I orient it in transverse like this, you have the right ovary here, the left ovary here. So the right side of the screen would correspond to the right side of the patient, and then the left side of the screen will correspond to the left side of the patient, but the top side will remain the same from skin deep. I am hoping this explains it much more. Mabel, your hand is up.
Hello, sir.
Yes.
Please, what is the name of the sign, the M sign at the top when you place the marker on the surface of the skin? The corresponding mark that you said that matches with the marker on the probe.
It's a marker. It's an orientation marker.
Okay, sir. So, sir, is there any instance whereby the orientation marker will be found at the bottom of your screen?
At the bottom of your screen? Yes. There are instances like that. Like I said earlier, there are instances where you have the marker at different locations. But because we are novices, because we are now starting, it is better for us to understand the standards before we complicate it for ourselves. There are instances where you find it down and are using. For instance, when you are doing a transvaginal or a transrectal examination, you may have it in different orientations. But for us being beginners, let's understand this first. Then we can complicate it later with other techniques. Am I okay? Are we on the same plane?
Yes, sir.
All right. So I am hoping everybody understands this now. Please, if you don't understand, show by hand or write a comment for us to read. Jennifer.
Please, the sagittal plane, I was off. I beg if you could go through over it for me.
Yeah, Jennifer, you're saying? Jennifer, we can't hear you.
I was muted, sir. So I was saying that the sagittal plane, I was off. I tried joining, but it took me off. But so I played it. If you could go back over it for me.
Okay, so let's do it one more time. Also, answer Wilson should also take note, since it's the same thing we are talking about for your question as well. So let's do this one more time. For again, I am hoping you understand the relationship between the orientation marker on the probe and its correspondent on screen. If you do understand them and how they work, then we move on to sagittal. I am hoping this image will help us understand it the more. When we put our probe in sagittal, we orient it in such a way that the marker here, okay, this is our probe, the lot in its length along our body. So the marker is the red part at the top here. When you have the marker at the top facing the umbilicus towards the head, then the part that is facing the umbilicus towards the head would be the superior aspect of the body of the patient, but it would lay on the right side of your screen. So if you imagine this probe taking a slice of this woman's body, then you would know that it will take the uterus and the cervix, the uterus with its cervix and some part of the vagina. So when you demonstrate it on screen, you will find out that the fundus of the uterus is at the right hand side, whereas the vagina is on the left hand side, meaning that the superior aspect of your body would be on the right hand side when you are in sagittal, whereas the inferior aspect of your body would be on the left hand side when you remain in sagittal. When you are in transverse, the right side of your body, when this probe is rotated 90 degrees anti-clockwise, the right side of the body, in this image, when it is rotated, the right side of your body would be the right side of your screen, whereas the left side of your body will be the left side of your screen. That is to say, this right side will be the right ovary, this left side will be the left ovary, and you have your uterus in the center. And that is how you would image it. So you can see that in this instance, we used a curvilinear probe. So you can see the curvature on screen as compared to the first image that we were watching, which was more of a linear probe. So it also gave us a flat section. The marker on this would be somewhere here, right side here, right side. If you have your marker on the superior or right side of your patient. I hope it makes sense now.
Yes, sir.
Excellent. So that is what we need to understand about probe orientation. So we'll end it here and we'll continue with the pattern recognition in our next session. Then our next class would be on how to image in obs and gynae. Then we'll be done with most of the stuff that we have to do. Then we move on to the practical sessions. Thank you.
Thank you, sir.
Thank you, sir.
Yes, Cynthia, your hand is up.
Sir, please, I have a question about the practicals that you've been talking about. Sir,
Okay.
please, is it that we'll be tasked to do a practical on what we've been taught, or we'll have a practical section of the theory taught?
We'll have a practical session of the theory taught. I would come to wherever you are. If you are in Adan, I'll come to Adan. If you are in Wa, I'll come to Wa. We'll arrange with an ultrasound equipment. Everybody will get to practice so that you have a feel and an understanding of whatever we have done.
So, sir, does that mean that that will happen when you are done teaching us everything, please?
Yes, please.
Okay, thank you very much.
You are welcome. Vida's hand is also up.
Sir, please, do we have another name for the S-plane?
Transverse.
Thank you.
You are welcome. Eva.
Yeah, sir, please. I wanted to find out whether the marker is also known as the notch.
It could be a notch in some instances. The reason why I'm not calling it a notch is that if you watch the images that I showed in the first instance, it could be an indentation as well.
Okay.
So sometimes you can have it as a notch. Sometimes you can have it as an indentation. In this instance, it's a notch. This is a notch, but here is an indentation. So you cannot always say it's a notch, but all notches are markers.
Okay, thank you.
Not all markers are notches.
Okay, thank you, sir. Thank you.
You are welcome. All right. Then let's have a great morning and let me prepare for your next batch. Have a nice time. Bye.
Bye, sir. Thank you.